Thank you for coming this morning to meet with the Columbus Group and the division and learn about what we're implementing and how things are changing. We have 3 speakers today that will be sharing information with you. So over the last few weeks, we have traveled around the state. We've been in every regional and satellite office. And so we wrapped that up last week and are offering this WebEx today for those people who couldn't be in person. So we hope that you will find the information helpful. At the end of this PowerPoint, we have collected Q&A across our travels, and so we've added them to this PowerPoint to help people. As Kat said, you can place your questions in the chat, but we will wait until the end of the presentation to answer those questions, because many of your questions will be answered by the presentation or by the Q&A that we have already indicated. We'll do a brief introduction of presenters. We're going to do an overview of the Columbus Group and what makes them qualified to do what we're asking them to do. We'll talk about the functions of the contract and the why behind them. We'll talk about the implementation timeline, and then we'll talk about looking at the reviews up close. Okay. So we have with us today myself. I'm Wanda Crocker. I'm the Assistant Deputy Director of the division. I've been with the division for 23 years. And prior to this position, I was the Director of Provider Relations, but I believe I have held all but maybe 4 or 5 positions at the regional office. And before that, I was a provider. And then Dan and Carrie will introduce themselves when they come on to speak. And Holly was one of our travelers and often was a speaker in place of me, but I don't think she's on today, but still honorable mention to Holly for weathering the travel with us. So, and Dan, I'm going to turn that over to you to introduce yourself and a little bit about Columbus.
That would be great. Thank you, Wanda, and good morning to each of you. I'm sorry we can't be in person today, but this is the next best thing. As Wanda said, my name is Dan Howell, and I have the privilege of being the project director for the Missouri project for the Columbus organization. We've been around for almost 40 years, I think 38 years and counting now. And we do really 3 things. Number one, we're a professional staffing agency for psychologists, psychiatrists, and other professionals around the country in the human service field. Secondly, we in 8 different states, we have care management, and I believe we have over 500 case managers that do work in the south and southeast portion of the United States. And then we're a consulting group, and that's the group that's partnered with the state of Missouri to do, and Wanda will show you the 4 or 5 areas of work that we're doing. But primarily it's going to be, and today is one of those days where we're going to talk about the TCM review as well as the provider relations tool. Personally, I've had about 37 years of experience in human service and healthcare administration. I'm a former hospital administrator. I'm a consultant for a number of years. I've been a provider like many of you in the room, as well as I had a 4-year stint as the Director of Developmental Disabilities in the state of Georgia. So I'm thrilled to be here, and hopefully we can go through the slide deck. And if you have questions, we'd be more than happy to answer those. One of the things that happened, we were awarded this contract in November of 2022, and we've had a number of meetings with Carrie, with Wanda, with Holly, with a number of members of the division staff, really talking about how we're going to implement this project. And there's been 4 people who have been part and parcel on our end to doing that. Myself as the project director, Beth Reiniger is the vice president of operations or quality improvement for the Columbus Group out of Bluebell, Pennsylvania. Elin Howe shares the distinction of being the DD director in 2 different states, one in Massachusetts and one in New Jersey. She is behind a lot of the writing and some of the expansion of the tool that you'll see on the provider relations side. And then Julie Flannery from the Columbus Group was all things internal for us. Next slide, please. What we have, as we go through, just throw out some names. As we talked about just a little bit ago, we talked that we were expanding the provider relations tool. Celia Feinstein, I've been saying she's out of Delaware. She's actually Temple University, and she's been helping us with that tool and some of the sampling, how we're going to be sampling with individuals. We also have a component of doing the clinical portion of mortality review, and Janet Simons and Karen Booth are leads on that. Eric Billington from Missouri is going to be our quality reviewer in our intensive therapeutic residential home. There's one facility right now in the Rolla area. It's a waivered service. It's a non-waivered service now, but part of the waiver assurances, they want to bring it to the waiver and expand that. But one of the things they have to do, it's my understanding, is have an outside entity review that program before June 30th. And we will be doing that. And then we are going into, we'll talk a little bit about the process committee, but we are going to be assisting the states with due process. And Lori Gillen from St. Louis will be helping with that. We have right now, the numbers are rising right now. When we put the slide together, we have 19 reviewers, both on the targeted case management side as well as the provider review side. Many of these folks come from various places around the country. Some are Missouri-based. Our hope is to find more Missouri-based reviewers, both for TCM and for provider reviews. That said, the state asked us to implement this a little bit more quickly, and so we're bringing in people from around the country. We have 4 mortality reviewers. They are licensed in the state of Missouri. We talked about Eric on the ITRH lead, and we also shared with you about Lori Gelman-Wallace and the due process coordinator. In your, I think the packet or the slide deck was emailed to you earlier. This is just a list of all names. I know some people are from Missouri, so you can pick out those names and go, oh, I know that person, or oh, I've heard of that person. So we just shared with you the number of people that we've put into our spreadsheet now. And again, with that, this is a living and breathing list that will continue to grow as we move forward. All right.
All right, so we wanted to share with you a little more detail about how the contract impacts the division. Because the first thing that people ask when you say that you're contracting something out, that you're asking someone else to do it is, well, are you doing layoffs? Are you downsizing staff? And the answer to that is absolutely not. The division has many unmet needs throughout all of the departments, not just a PR and tax, but many other units. That's not going to say that any of our tax or PR are going anywhere, because they're not. We are replacing we're contracting with Columbus. We're replacing that with other functions. And so I wanted to share with you what those are. So we will be transferring to Columbus the clinical RN component of the mortality review that is coming off of the quality program RNs at the regional offices. So that is that one part that the quality RNs do after the provider does part 1, then our quality program RNs go in and evaluate all the documentation and everything that happens surrounding the event. And then it goes to a local mortality review committee and then an executive mortality review committee. So that part that our quality program RN fills out the evaluation of the event, that is what is going to Columbus, none of the other components. So that is making room for the HRST. I think everybody has heard about the health risk screening tool assessment by now. That is growing much larger than it was originally designed to do. We're using it for many other purposes. We're doing residential, which the quality program RNs will do. We're doing the non-residential, and it's also the tool, the assessment tool for the home health system. So it's a much broader utilization, which means our RNs have more technical assistance, more effort, getting those onboarded and helping people with their processes. So we're making room for the RNs to focus on the Hearst. We have asked Columbus to manage and facilitate the due process review committee that is currently managed and facilitated by the quality program QES at the regional office. So that is everything related to the due process function that our regional office currently does, receiving the information, making sure all the information is there, collecting additional information if it's not, facilitating the committee, and notifying of responses or decisions. So in turn, our QE staff are going to be focusing on individual rights and due process, becoming subject matter experts. We have well over 3,000 rights restrictions in the state. And considering that that is predominantly focused on people receiving residential services, that's a lot. And we've seen a wide variety of what those due processes are for. And many times the due process is not for the individual, it's to protect staff. Or people are asking for due process because they've been told to ask, not because they believe it is a rights restriction. So we obviously don't have one consistent definition statewide of what a rights restriction is. And then we have way too many rights restrictions going on. So we'll be working with Columbus to collect data and information about what they're reviewing so that the QESs can then target training and outreach and education to try to get the due process number, one, reduced, and two, to clarify and provide a singular definition that we're all following on what a rights restriction is. We will be asking Columbus to take on the provider annual performance reports from the quality program QES and from provider relations. That is generated by QE and distributed by PR to waiver service providers once a year. And they're also taking on the provider site review, previously known as the provider relations review, which is an expansion of the earlier version. So we've already talked about what QE is going to be moving into. So we'll talk about how that impacts PR. So you might remember prior to COVID, our business office went to every provider annually and performed a general revenue service review. So any provider who was delivering services funded by general revenue were reviewed by the business office. Well, they ceased doing that during COVID, and as COVID lifts off, when we get to the end of our MOE, PR will be taking that. The business office will not resume it. PR will be redesigning it, and they will be doing that review. Additionally, we're asking Columbus to review all direct service providers. And so that's roughly 474 providers. That leaves another 200 to 300 providers that do not currently have a review and have never had a review. So our providers of OT, PT, ST, behavior services, transportation, SME, assistive technology, EAA. There is no look behind or review on those other services to determine whether those services are compliant with our waiver or contractual requirements. So PR will be taking on the purchase of service review from the business office, and they will be implementing a service review of all of the contracts that are not being reviewed by Columbus. Plus continuing to do the ongoing technical assistance to providers and working with Columbus, as you'll see in the plan, when additional remediation is needed. Most recently, it was our last addition to the Columbus bid. We added the TCM annual review from the technical assistance coordinators at the regional offices. I think everyone is aware that part of our initiatives in the last year or so is to increase the number of support coordination statewide, therefore decreasing state support coordinator caseloads. So if you consider that a state support coordinator's caseload was running 90 to 100, and a private caseload runs about 35, we need 2 support coordinators on the private side for every single state support coordinator. So by adding additional support coordinators on the private side, that is going to increase the tax efforts on waiver assurance requirements and the amount of technical assistance that they're providing. So we had to make room for the tax to be able to take on and offer that technical assistance and ongoing waiver assurance to TCMs. So that's why we have asked Columbus to take on the TCM annual review. And then Dan had mentioned the intense therapeutic residential habilitation. That is a brand new service, so it's not coming off of anyone. That service specifically requires us to analyze how that one provider is doing and develop and provide data to CMS showing that one, that service is HCBS compliant, and two, that the service works in order for that service to be expanded into other providers. And we have many providers who are waiting to expand and offer that service, but they can't do so until we get an independent evaluation of the provider systems. So that's written into our waiver. It's something we had to contract for, but it's not coming off of anyone. So why are we doing this? So we are doing this to develop a best-in-class quality assurance system. We want to get to the point where we are looking at systems and ensuring that providers have systems in place for success. We are evaluating for compliance for HCBS rule. You all are probably aware that the HCBS rule goes into full implementation in May of this year. That means at that point, CMS expects states and providers to be in full compliance. The state has asked to be placed on a corrective action plan, which is okay. CMS actually recommended that states ask for a corrective action plan, which most states have done. And the reason for that is if you don't ask for a corrective action plan, you're kind of raising your hand and saying, we're perfect. Come look at us. We're perfect. We've done everything right. And we have HCBS wrapped into everything we do. Asking for a corrective action plan admits that we might have some room to make things better. So HCBS compliance for the state does not come solely from the division. The HCBS compliance means every one of our contracted providers is HCBS compliant as well. So we don't get to compliance by ourselves, we get to compliance together. So what that means is we know that we have providers who aren't compliant. And you say, well, Wanda, how do you know? We know because when PR does 3-year reviews with providers, we have some providers who ask us what HCBS is. We also have providers that we were out there to do the last review with, and they didn't have policies and procedures. So we developed those with them and got them in place. But when we came back, they weren't able to produce them, which then tells us they're not implementing it either. So we know we have some work to do. And that's what we're asking Columbus to help us with. You'll see in some of their questions and some of the approach we're taking is very HCBS rule specific related to waiver providers. Also keep taking a comprehensive look at provider qualifications and systems. For roughly the last 3 years, our provider qualifications have been less than the CMS required 86%. So providers of waiver services have 3 waiver assurances that PR reports out on. One of them is total number of staff reviewed for background screen and education. One of them is total number of staff reviewed and how many were compliant for core training. And one of them is the subset of that specifically related to personal assistant and respite. And they, one or more than one, have been non-compliant for the last 3 years. So for the last 3 years, I've been writing corrective action plans, explaining how the division is educating providers, what our outreach is, what our remediation is. But at some point, those efforts proven to be inefficient, something else has to happen. Because while we continue to work with providers, when CMS comes in and does an audit, if staff aren't qualified to provide the service, they ask, did you recoup the funds for the staff who weren't qualified and delivered services? We want that answer to be, no, we didn't have to because we got it all cleaned up, right? And we don't currently recoup funds when staff aren't trained or have education qualifications missing, but we do have to recoup funds when we go in and find a disqualifying offense. Um, and, um, and there's no exception on file. And we do that by having the provider report to IMMAC. So luckily that doesn't happen very often, but it does happen. But CMS would question, why aren't you doing that anytime a staff is missing training? So we want to help providers get systems in place and get that enhanced and get that percentage up before someone comes knocking and starts to tell us how we're going to remediate the situation. Obviously, the ability to review additional services that PR is taking on and move towards a systemic review. So our timeline in December, from December to February, as Dan said, we awarded the contract in November. We had to wait 30 days to even begin working on the contract, as we had to allow other bidders to contest the decision, which they had 30 days to do. So luckily no one did, because contesting takes a lot of time. We might not be here today if someone had contested the decision. But starting in December through February, we started working on processes, developing tools, getting Columbus staff access, as they will have access as PR and tax do, and providing training and developing this training. So in March, we've been doing training with Columbus staff. We've been doing this outreach with providers. In March, Columbus shadowed 3 TCM reviews. So they went with a TCM TAC and participated in TCM reviews as part of their training. And we started our round robin meet and greet across the state. So in April, sometime this month, the plan is for the TCM reviews to go live. That Columbus will fully take on all of the TCM reviews that the TACs were doing. In April, we are piloting provider reviews with all 4 of our state operated programs, as well as 4 community waiver providers who have volunteered to be part of the pilot. And we're offering this web event. In May, we're projecting to go live with the provider review after the pilot. And then in June, you'll see some of the other functions. This is by the end of this fiscal year, where due process and mortality review will be implemented no later than that. But we'll talk about the other portion, the provider annual report, later, and where that's going to fall in. So now I'm going to turn it over to Carrie Williams, who's going to do the TCM annual review portion.
Good morning, everyone. My name is Carrie Williams, and I am the Director of TCM Services. And as Wanda said, I'm going to be covering the TCM annual review process piece of that Columbus contract. Next slide, please. So as has been mentioned, with the TCM annual review process, Columbus is going to take that current process in place, the current tools that TACs are utilizing, and they're just going to pick up that process. So there are no changes to the TCM annual review process. If you are a TCM provider, the only change that you are going to see through that process is, instead of your regional office TAC providing that review, it's going to be Columbus staff. Also, for that process, it will continue to be a combination of a desk audit and an on-site review. So again, that is no change. Since the process and the guideline was initially developed, and that was back about probably 2011, 2012, that was written into the process at that time. So you will continue to see a combination of that desk audit and on-site review. There will be things that Columbus will be reviewing, for example, in the Seymour system, or some things within the individual record review, before going out there and doing that on-site piece. Also, as has been mentioned, TACs will continue to work with Columbus and that TCM provider to transition the process. So the TACs are not going away. They will still be involved in those other duties and processes that they currently work with you as a TCM provider on. So, quarterly ISP reviews, all the things around level of cares, information gathering around audits and follow-up and remediation with some of those other audits, technical assistance. access requests, all those things that they're currently doing, they're not going anywhere. It is only this piece of the TCM annual review that is being transitioned. The tax will also continue to work as part of that annual review process in terms of identifying or pulling the sample names for the individual record review portion of that TCM annual review, and then they will provide those names to Columbus. The reason for that is with the tax continuing to do the quarterly ISP reviews, that process is based on performance measure, waiver performance measure reporting, and we have to report the results from those quarterly ISP reviews as part of our waiver performance measure reporting. And so that is a random sample that is pulled each quarter and given to the tax to complete. And so we want to do that cross-reference just to ensure we're not reviewing all those same names that Columbus would be reviewing. So that's where tax are going to be involved in that piece of the process to pull those sample names for the individual records review portion to provide to Columbus. Also, that TCM review continues to be an annual review. Again, no change for those TCM providers. They are reviewed on an annual basis. Next slide, please. Okay. The next few slides really are going over the TCM annual review, those requirements for that review. So again, as we have stressed, there is nothing changing. We are not changing the requirements of this annual review. However, we did think this would be a good opportunity just to review those areas of requirements that are reviewed during that annual review process. So the first thing you will see here is the evidence that case management staff meet qualifications. So, do they have the educational requirements to provide the TCM services? Have they had the appropriate training? And that's all outlined within the TCM contract, but have they had the appropriate training? Was it within those specified guidelines? Also looking for the records that they are maintained for each of those individuals who are receiving support coordination services from that TCM provider. And looking to ensure that the annual ISP is prepared according to guidelines. We talk about HCBS, we talk about the settings rule. A piece of HCBS is also around requirements in terms of the person-centered planning process and requirements of the person-centered service plan, or the ISP. So that is a piece of that review as well, looking to ensure those requirements are being met within the ISP. Next slide, please. The assessment and level of care evaluation is accurately completed. So looking for level of cares that are timely. Were they completed timely? On an annual basis for those redeterminations? Were they reviewed and were they approved by that SC supervisor? Looking for evidence that individuals were provided choice, and choice in terms of those waiver services, as well as the waiver service provider. So looking for that evidence of documentation that occurred. Also, as part of that TCM annual review, looking for the evidence that the monitoring was conducted, that findings were identified and entered into the IQMFD system. So as you all know, that monitoring is really driven by the services that individual receives. It is individualized. So if I'm an individual receiving residential services, my monitoring is going to be a monthly face-to-face visit. That's what my monitoring is going to look like. But again, it's driven by those services. So a piece of that process is looking to ensure the monitoring occurred per what is authorized for services for that individual, identified and then followed up in IQMFD. Also looking for evidence of implementation of the UR process. So, as services were requested, the individual was assessed for that need, looking for the evidence that UR process was implemented, as well as evidence that the process is followed for individuals who are moving. So transferring, transitioning, is that process being followed? And then also looking at that evidence for the TCM provider, that if there are action plans that are identified as a result of abuse, neglect, a death inquiry, an investigation, did that agency follow up on that plan of action? So an example of that, I think the most common thing we see is that maybe something is identified in terms of an ISP. Maybe there's incorrect information in an ISP. Maybe there's additional information that needs to be added. So there may be a plan of action that goes out from a regional office requesting that ISP is updated to include that information. And so did that occur? Also looking for evidence that the individual was given that annual rights without limitation. Now looking for evidence that or a system that ensures that the division's information management system is being kept updated. So right now that is Seymour. Is that demographic kept updated? Does the individual have correct contact information? Is there correct guardian information that would match that ISP that's been updated within the Seymour system? As we transition over to the connection case management system, at that time, it would be ensuring that that information is kept updated within connection. Looking for evidence of a 24/7 on-call system. Per the TCM contract, TCM providers are required to have a system and process in place for 24/7 on-call system. So evidence that that has occurred, and evidence that QA processes and systems are in place. So an example of that is an annual consumer satisfaction survey. That is a requirement per the TCM contract that agency have a process for annual satisfaction surveys. So that's an example of a QA process that review would be looking for. And then the last thing you see here is logging. And for the TCM provider, that is that billing component. So reviewing 3 months worth of log notes or billing documentation to ensure those billing requirements are being met. This slide then speaks to the TCM annual review process, just some things to remember, reminders around that process. The TCM provider will continue to be notified 30 days in advance of that annual review. That's going to look the same on the service provider side of things, as you'll see later with that review process. Providers are notified 30 days in advance, and then that meeting is scheduled. Columbus will then collect that data. They will complete their review of the information in those areas that we've covered. And as part of that process, there will be an exit interview, and the TAC will be invited to that exit interview as well. And then that way everyone's at the table, everyone's hearing the same thing, given the same information. That way if there are questions down the road, additional technical assistance or education that needs to be given, then the TAC is aware and in the loop of that information as well. As you know, part of that process now is with identifying those findings and then entering those findings into IQMFD. So that could also include positive findings or positive outcomes. Maybe Columbus will identify a really exemplary practice or process that a TCM provider has in place. And so that would be an example of a positive outcome that might be entered. And then the final piece really of that process is pulling that information together and providing that written report or that summary, that annual TCM review summary, and then sharing that with the TCM provider. TACS will receive a copy of that as well, and then TACS will be distributing that locally to their region. And that concludes the annual TCM review process. I will turn it back over to Wanda.
Thank you. All right, so there are a number of changes to the PR review that Columbus is taking on and expanding, and so we want to share that with you. So the first thing is an expanded review. If you are a waiver provider, you're aware that we currently PR currently has a review cycle of every 3 years. So 100% of providers over the course of 3 years. For the implementation phase of the Columbus organization contract, every waiver provider will be reviewed annually for 2 consecutive years. So that means in this first year, they're targeting 75% of our providers. In year 2, they're targeting 100%. And then those providers who still need a second year will get a second year in year 3. During these first 2 years, we'll be collecting baseline data. And the purpose of that baseline data and the reason that we are expanding the sample is we want to go to a 1, 2, 3 year renewal after the first 2 years. So we need that baseline data to help us develop the criteria under which what tells us that a provider is super good, has everything that they need in place, and therefore we're not coming back for 3 years. What tells us that a provider is really struggling, doesn't have systems in place, is missing policies and procedures, not implementing HCBS. So we're going to come back and see them in 1 year. And what tells us that a provider is in that middle place, so we don't come back for 2 years. So we need that data in those first 2 years to tell us and help us design what quantifies a quality provider. There's also another reason for expanding the frequency size that you'll see here in a moment. So we will be enhancing the tools from the pre-COVID provider relations tools. You might remember prior to COVID, the PR review wasn't just about staff qualifications. It also was about your policies. It was also about your contractual requirements. It was also about are you staffing at the required contractual level, or what does it align with what's on your ISL budget? Those things we have not been reviewing during COVID. During COVID, we've only been reviewing staff qualifications and your HCBS compliance and your restraint policy. So we condensed it during COVID. So we're going to go back to what it was before, and we'll be adding systemic reflections. So every question that you're going to see when you have the tool, it has been interpreted with the Division and Columbus that we've worked together to create this tool to determine how are our providers implementing HCBS? What are their systems like? Are they in compliance? And how much are we in compliance? So, in addition to the items that we talked about, I mentioned earlier the HCBS settings rule requirements. You're going to see a lot more when Dan comes on and talks about the CAHPS survey. But we will be expanding the review to include a much more in-depth look into how providers are implementing the HCBS rule and are they compliant. So the items that we've added to the review, the Division and Columbus agreed that we needed to add these items because providers aren't meeting those standard requirements or current standards of practice. Not all providers. We say providers and globally, but that's not all providers. Obviously, we have some excellent quality providers, but all it takes is someone coming in and auditing the 5 providers who are not our high standard providers to extrapolate that as a state, we're not compliant. So I mentioned we're going to be developing enhanced tools from the pre-COVID provider relations. I had mentioned earlier that we'll be reviewing providers of Medicaid waiver DSP services. So that is residential, day hab, community networking, employment services, anything that requires a DSP to deliver. Those are the providers that Columbus will be reviewing. In addition to the services related to DSP, this will be expanded to include professional or semi-professional services. So I mentioned that as Columbus comes on to do this review, PR is going to be developing a review for all professional and semi-professional and all other services for providers who don't have DSPs on their contract. So we're asking Columbus to do the DSP service review and the professional, semi-professional, because if they don't do the OT, PT, ST, community specialist, behavior services, crisis service, support broker, then you would have to have a second review from PR. So Columbus is combining both of those 4 providers of DSP related services, and then PR will pick up the ones that don't do DSP services. Just to give you guys an idea of the review cycle, if you were reviewed in May of 2020, 21, 22, most likely you'll be reviewed in May of 2023. We're going to try to keep it consistent with your last review cycle so that you can kind of anticipate. Now, that might not come off exactly right, considering that, you know, they're going to attempt to review 75% in this calendar year. So there might be some maneuverability there, but we want to give you at least an anticipation of when they might contact you. So like the TCM TAC, the setup process is very similar. Columbus will schedule with the waiver provider 30 days notice. Columbus will have the same access to the system as tax and vendor service coordinators do. But Columbus will pull the reports to determine the samples. Unlike the TAC and the TCM, PR doesn't have a separate waiver assurance that requires us to eliminate duplication. So Columbus can pull those reports themselves. Now, in the first few months, because nobody said our system is easy, Columbus might need some assistance of pulling those reports, and PR will help them with that as they learn how our system works. Like PR, before them, Columbus will review providers' last certification or accreditation, any corrective action plans that the provider is on, and data reflecting trends in EMT. So they're prepared coming in to know and have a picture of that provider's performance based on the information we already have. Like PR, Columbus may request information prior to the on-site review to complete partial remote review. Things like staffing patterns and staff schedules, policies, things that can easily be transmitted and reviewed remotely. And PR has been doing that even before COVID, that we had a hybrid system in place. It just works a little easier to be able to focus on staffing patterns and schedules in front of a computer versus trying to look at it on paper in person and taking up providers' valuable time by doing so. And they will conduct a brief entrance meeting. So part of what we're asking them to look at is provider capability review. Where are you as a provider ensuring that you have the capacity to deliver services with quality? So we're asking to look at, do you have a philosophy, mission, and capacity that results in supports directed to inclusion, community participation, health, safety, and welfare? Those speak directly to the HCBS rule. And so that's where we're really honing and focusing, along with some other factors, looking at your policies, looking at how your procedures, how do you implement? Not that just that you say you're going to do it, but how are you doing it? How are you making it happen? Are you training your staff? Is it a one and done? Or are you having frequent renewals and refreshers on the HCBS rule and the expectation for community participation and inclusion? Are you actually monitoring your staff to make sure that they're implementing the expectations? What is your system to make sure that you are implementing the HCBS rule and all other waiver requirements? That's what we're asking Columbus to look at. Do you provide the tools and materials necessary for your staff to effectively perform your duties? And do you follow applicable laws and state policy regarding responding to abuse and neglect and serious incidents that could threaten the safety or well-being of a consumer? Are you ensuring proper handling of all consumer records, their security, accountability, confidentiality, and retention? That's not really something new, but they're looking at your system, okay? So the second one I want to spend a little more time on, because this might kind of maybe confuse or concern people. Ensure proper handling of all consumer financial benefits and income, including security, accountability, confidentiality, and retention. Columbus is not auditing providers. They're not auditing how you manage a person's benefits. You may be aware that the division is working to move out of being representative payee. So right now, if we are a representative payee for someone, then our business office completes a review of how those funds are utilized by the provider. And in turn, we're audited by Social Security to see how those funds are being managed. As we move out of being representative payee, I think we're still representative payee for around 1,500 people in the state, but we have migrated out whole regions of representative payees where that office is only doing like 5 or 10 compared to hundreds that they used to do. So what that means is we're not going to be looking at from an audit perspective, from a business office perspective of how you're handling people's finances when we're no longer representative payee. That doesn't mean that you're still not responsible to have a system, because when the new representative payee is audited by Social Security, they'll be knocking on your door to say, I need evidence of how you've utilized their funds. And so this step is about looking at your system. It's not looking at receipts. It's not looking, did you balance a checkbook? It's not looking at that. It's looking, do you have a system in place to assure that when the representative payee is audited, that you're prepared to respond and support that activity. So a system. They're also going to be looking to see if you as a provider conduct annual satisfaction surveys to self-assess, improve, and expand services. Now, this is not currently a requirement, but this is a core component of the HCBS rule. How do you know if you're doing a good job as a provider? How do you know if you're doing quality if you're not asking people how you're doing? So no, this is not a requirement by the division, but it is a component of HCBS. And just because it's not a requirement today doesn't mean it won't be tomorrow. And it would be something that CMS would be looking for, we think, when they come to audit us. So someone asked me in a previous call, this is best practice, so I don't have to do it, right? And you're right, it is best practice and it's not a requirement by contract. But this is how we're going to determine whether a provider meets that 3-year renewal. Best practice is what gets providers to the 3-year renewal cycle. So no, we can't make you do this today. We're trying to guide you into best practice that sets you up for success with CMS audit, HCBS audits, and with our own review system that can help you get to that 3-year renewal instead of continually having an annual renewal because you don't have best practice in place. So, so that is what that is for. Waiver assurance related, I mentioned earlier that we have not been compliant with all 3 of our waiver assurances under the provider house for some time. So the other big change right now, provider relations reviews 100% of staff delivering personal assistant and respite. On the other services, they pull a much smaller sample. In some instances, only 3 staff per service. So the things that PR looks for and that Columbus will look for are background screening within 2 days of hire prior to contact initiated, proof of education, understanding that right now during Appendix K, providers didn't have to collect proof of education for people hired during COVID, but that is about to end. And so, you know, those people that you hired during that time period, if you did not get proof of education on them, you need to start doing that because those all have to be in file by November of this year. We've already heard from some providers that they're having difficulty or finding out now that their staff didn't have high school diploma or GED. So need to start looking at that now. Well, they'll be looking at required training, CPR, first aid, med admin, abuse and neglect, ISP training, PBS, crisis intervention, if required. It might surprise you to learn what our 3 trainings that are consistently in the top 5 are. Most people think medication administration. Other people say for CPR, first aid. I can't poll you guys. I actually should have polled you. That would have been a good poll for the presentation. But our biggest consistent in the top 3 is ISP training. ISP training is arguably the easiest one to obtain. You do that internally. You don't have to use an external source. It's about, there's many different systems you could use to do ISP training as those ISPs come in. Followed up by abuse and neglect and positive behavior supports, which are free trainings available virtually through Elias. So the free trainings are consistently in the top 5 of not being delivered to our staff. So why? That's what we're after. Why? What's the barrier? We did in this last quarter, October through December was the first quarter in many quarters that we were compliant with all 3 waiver assurances. The reason I hypothesize that they were compliant is, one, last year, Amy Rutledge and Dawn Cochran conducted a small, well, it wasn't very small, was a work group, and we invited the 60-some providers, I think it was in the 60s, maybe 70s, who had been required to self-audit in the previous 5 quarters due to having at least one staff not qualified in one of these areas. So they had that work group. They looked at what are the barriers, shared resources, how can we make it better, what kind of system. I think that could have helped. Additionally, what could be impacting that is our DSP value-based payment, right? A lot of providers are aiming for that eventual, when you get through all 3 stages, 3% of billing, which for some of our providers is a substantial amount of billing and a substantial amount of value-based payment. You cannot pursue the DSP value-based payment until your staff meet core requirements. So you can't, as Heike would say, you can't skip the meal to get to the dessert. You have to have core training requirements in place before you can pursue the value-based payment for enhanced training. So I think that maybe those are some reasons that we might have seen an increase in compliance, but we're not sure. We also don't know, with the small sample that we've been reviewing in the past, was that is our result low because we're not sampling enough people. So a provider, let's say, who only has 4 staff, if one staff is not compliant, you're at a 75% ratio. So is it because our sample size was too small that that we weren't compliant? We won't know until we have bigger data set to evaluate and look at. Someone also asked at our training, and I forgot to ask this to answer or add this to the Q&A at the end. They asked, you know, during certification, will Columbus not look at these things if certification does? And the answer to that is Columbus will always look at this regardless of when certification comes. The reason for it is certification also has a waiver assurance related to qualifications. Somehow their waiver assurance is not having as the struggle that provider relations is. And I think there's a reason for that. When PR looks at this information, we don't just look to see that it exists. We look to see that you had a continuum. So when we look at CPR first aid, we're not just looking to see, do you have a current certificate, but did you have congruent training from the last one? Or did you have a 6-month lapse when staff wasn't in compliance with CPR first aid? So we're looking for the overlap. Did you get your staff trained before the expiration of the previous training? And I think that is the difference. And that is key to a provider's system of showing how they manage their training and onboarding processes so that they don't have those lapses in training. So I think that is the difference, but we won't know until we have better data. Site reviews, the things with asterisks are things that provider relations is currently looking at. And so service documentation reviewed for requirements previously outlined in the PR review, that is just looking at basic service documentation requirements. Do you have a date, a from and to time, the person's first name, last name, middle initial, or date of birth? Do you have the staff sign it, print their name, and add their signature and date it? So core requirements. If a provider, if we go in and either PR and now Columbus, and a provider is void of any documentation, to prove the service was delivered, we have the provider self-report to MMAC. We're looking for format. We're not auditing you. We're not comparing against your billing system. We're looking to make sure your documentation is compliant with expectations. But if your documentation doesn't exist, then we ask that you self-report to MMAC so that they can look into it and they can appropriately address the lack of documentation. Environmental tool using the Division ISL tool guide. So what I want to say about this is, it is a guide. The Columbus Group will not be coming in and looking at expiration dates in the refrigerator or the cupboards. They will not be looking at the thermometer to see your refrigerator is at the right temp. They are doing what any division staff should do when they enter into a location of service delivery. They are doing a scan of the environment to make sure that that environment meets standard health and safety. If I'm walking up the front step and there's a step on the front that's broken and I almost fall through it, that's an obvious issue. If I walk by the bathroom and I look in and there's a wall full of mold, that's an obvious issue. So it is looking for the obvious environmental scan, which is what any division staff, and hopefully any administrator or professional manager or house manager checks for when they walk into an environment. Okay. Medical records, looking at a system that you have a system to maintain it. We're still working on that. That's why there's not a huge amount here. Staffing patterns for ISL, group home, and day hab. Are you meeting the staffing requirement? They're evaluating, do you have sufficient RN and professional manager for coverage of group homes? Because those things are contractually required. So are you meeting the contractual ratio? And again, if not, that is a self-report to MMAC, just as staffing patterns are. We're looking for nurse delegation at day hab medical. If you are billing dehabilitation medical for anything other than mobility, you are required to have an RN consultant for that service. So do you have one? Do you have evidence of delegation? And the big one that we're changing is CAPS, not CHAPS. It is a survey and it is an HCBS supported survey. And I'm going to turn over to Dan, and Dan is going to talk a lot more about the CAPS survey.
Thanks, Wanda. So in your packet of material, I believe it works, and if it doesn't, just cut and paste this into your browser. It's the CAP survey. It's the Community Assessment of Healthcare Providers and Systems. It is a survey that's sponsored by CMS, and it is a cross-disability for adult survey. It is a rather lengthy survey, and I'll talk to you how we're going to administer that in a second. So if you just want to move forward, Wanda. It literally is a 96 question with about 16 of those being demographic questions that we would be talking to individuals in your services, and we'll generate a random sample. And I'll share with you in a little bit how we'll do that. But it's grouped in the following topics. Are you getting the services you need? Can you communicate with your provider? Do you have choice? And the big one truly is community inclusion. Next slide. Again, there's 96 questions, but there are 15 or 18, if my memory serves right, that are demographic in nature. Some may not be applicable to the individuals, and our reviewers will just put NA. They won't score it negatively. They'll just put NA. Or if an individual, if they're selected and starts the interview process and for some reason is having a bad day, isn't feeling it, doesn't want to sit through the remainder of the interview, we just stop there. No harm, no foul. If that individual is in an employment setting, day hab or supported employment, we'll ask 20 or pre-voc, we'll ask 21 questions. There's a survey for that as well. Okay, Wanda? How we're going to do this is we're going to take a sample size of 10%. So if you have, based on all of your authorized services, if you have more than 100 people in a service, we'll interview 10 people that have that service. If you have 27 people, we'll interview 3 people. And such. So there's a lot of providers that have less than 10 or 15 people in a service or in a waivered service. We'll interview 1 to 2, so it won't take very long. So as we look at developing how long we're going to be on site, it really is based on the number of employees you have for record review, but then the sample size, the interviews will take some time as well. We're going to try not to duplicate services. So if that individual has 3 or 4 different services, they're not going to be 2, 3, or 4 different times. It's a one-time deal. We'll leave it's going to take up to 30 minutes to complete the survey. Staff members, we love a staff member to be present. We don't want guiding or answering questions or influencing the individual. That said, some people have a lesser ability to communicate than others. And consequently, they may need a guardian, or they may need a loved one, or somebody who knows them really well to help them with answering those questions. Next slide, please. One of the things that we're also looking at doing is Missouri has a Missouri First initiative with technology. So if you are a part of that, do you have a policy or a document on assistive technology? If so, what's your commitment to assistive technology? When we're out in the field, we would love to see AT in practice. So if you have it, we'd love to see it. As Wanda said, the ongoing HCBS community compliance. Back in 2014, right when this was enacted, there were provider self-assessments that the majority of providers completed to see where they were from a compliance standpoint. We think it's a good idea for you to look at that again. As Wanda indicated, they're getting closer and closer to saying there's no more do-overs with HCBS. So Missouri wants to assert that we are in compliance. One of the ways to do that is for each and every provider doing that self-assessment. So we're going to be asking, have you done a self-assessment? If so, what can we see the findings from that? Do you have any services that are in heightened scrutiny? Heightened scrutiny basically is environments that isolate. So we want to make sure that people have the ability, there's no locked doors that they can't get out of within reason. They're not on the grounds of an institution. They get out into the community as often as they want, when they want, again, within reason. Okay. Thank you, Wanda. Go ahead. Billing practices. Wanda said, we're not accountants. We don't balance checkbooks. We want to see that you have a policy on financial dealings and billing. Then show us if you can. That's what we're looking for. Show us the system that you have with respect to billing. Okay. Next slide, please. One of the big issues around the country is the use of cameras. So do you have any cameras in your home or day program? And if so, where are they located and how are they used? And then do you have division approval for those? As we've talked, we said we'd have an entrance, and then during the exit, we will tell you all of the great things that we found in the review. If there are some findings that need some attention or some issues that need to have attention, we'll share those with you as well. We're going to develop a summary, enter that in the IQMFD system, and then provide you 30 days to remediate those. If there are some findings or if there are some issues that need some greater attention, we're going to ask you to submit a plan for us. We'll look at it. If we still have questions, we'll send it back to you, all within that 30-day window after the day of the exit. If we cannot come to an agreement, if we don't think the plan of correction is suffice, What we'll do is send it back to you, as well as notify the vendor service coordinator to follow up and then continue with you going forward. One of the things that's really important as a former provider, I always liked to know the test before the test started. And I know somebody in the chat was asking, will they see the review tool? And the answer is yes. There is one last edit, and right after this, we are getting on a conference call to do that. We'll be sharing it with the division today. We've been talking all along with Wanda and her team, so I don't think there'll be many edits. We are going to pilot it, as Wanda said, in the next 2 to 3 weeks, and then we will send it out to everybody so you know what we're going to be looking at. But more importantly, is we're also going to show you the guidance that we're giving our reviewers. Again, we're coming in from all different parts of the country. What we want to make sure is that what happens in the northeast portion of Missouri is the same as the southwest portion of Missouri. The caveat to that, sometimes we interpret things differently because we're human beings. And so our team, though, will be looking at this almost on a weekly basis. We'll have calls to say, okay, what did you see? What did you see here? How did you do that? So we can be as consistent and uniform as possible. After the pilots, there may be a few modifications and changes to the tool before we start in earnest, as Wanda said, in the middle of May. All right, Wanda. There you go.
All right. So as I said earlier, April is our pilot time. All state operated programs and 4 community provider volunteers. One of those 4 is our largest provider in the state. So we are positive that when the Columbus group gets done reviewing those records, they will be well versed in the process. Doing this WebEx, and we're refining tools based on the pilots. We'll be posting tools, obviously revising what was the PR review to reflect the Columbus implementation. We will have another WebEx if we make significant changes. We do plan on full implementation by the end of this fiscal year. I do want to talk specifically about a provider scorecard and provider performance report. So if you've been with us for many years, you've heard provider scorecard before. We've been probably talking about it for a long time. With the implementation of Connection, we have the ability to offer public-facing information. Our intent, and I believe we can get there with Columbus, is specifically because of the data that we're collecting with providers. The intent is to design a public-facing scorecard, and it is in their contract to do so. Now, we anticipate this not rolling out until next fiscal year or maybe the year after, because we need core data to tell us what we need to put in a scorecard. But this is something that would be available to the public when an individual is trying to choose a provider. Right now, they have no information about that provider. They're probably picking the provider with the name they like the best, or the one that's closest to their home, or something like that. They have no idea what the provider's performance is. So what I want to tell you about this is when we are ready to start developing, we will convene a provider work group to help us determine what and how we represent information on the scorecard. So this is not done in isolation. We won't just do something on our own and put it out there. We will want your feedback. We understand it's scary to be transparent. You all demand us to be transparent every day, and we in turn are going to ask that of you with the families that you serve. So wait for that to come. Probably next year we'll have an outreach for participants in that work group. And then the provider performance report. Right now, that provider performance report I mentioned that the QE and PR were doing together. We are transitioning that to Connection or to Columbus, but we are waiting until Connection goes live. Instead of having them take the current format, we want to wait until Connection goes live and we can design something different and new based on that data. And by time Connection goes live and we transition, Columbus will have gathered a significant amount of data for us to look at whether we need to change what that performance report looks like. So I've added a list of questions from our walkabout. Many of the questions we got were questions that were answered in the presentation. So what I did was try to pull the questions that aren't answered in the presentation. Will Columbus recoup funds, and under what condition? This process will not directly recoup funds. That is not the division's function related to Medicaid waiver, but providers will be required to self-report to MMAC when the following is identified. You had staff with disqualifying offenses with no exception on file. That means they're absolutely not eligible to provide the service. We have seen MMAC audits where MMAC has recouped for this issue. So if we find that, you will be required to self-report to MMAC. You're not meeting your staffing patterns. You don't have a group home or RN provision at your group homes. There's no documentation for the service delivered. So those are the areas that intersect with what MMAC does, but we will not recoup. You will self-report to MMAC, and then they will take it from there and determine what action to take. Why is there a pilot for provider reviews, but not for TCM annual reviews? The TCM annual review, there's no change to content. It's simply a change in who is conducting the review. So we didn't feel that there was a need for a pilot. And shadowing seemed to, as someone mentioned in the chat box, that they experienced one of the shadowing events and thought it went really well. The only difference is providing it, whereas a provider review has new components. Does this review apply to accredited providers? Yes. This process applies to all providers of DSP services, as was the previous PR review. And I know that we had some concessions and the previous PR reviews for accredited providers that the guidance said that anything not included in the accreditation report would be reviewed by PR. There is a lot of information on the PR review that's not reflected in accredited reports. They don't tell us what they reviewed for your staff and what was missing. They don't tell us how your staffing patterns look. There is a lot of information not available. So even those, if you are accredited, you still had a PR review. Now you might not remember because we've not really done the full one since before Columbus. But yes, it continues to apply. I kind of mentioned this in conversation in the presentation. Some of these things are not requirements. I don't have to do it, right? Correct. However, this information is being gathered to develop 1, 2, or 3-year review cycles. 3-year review cycle parameters are sure to include best practices. Only through evidence of external systems and internal systems and self-evaluation will a provider obtain 3-year review cycle. So no, you don't have to, but that's how we're going to get to the 3-year cycle. If certification is coming this year, are there things you will remove from the review so as not to duplicate? No. There is minimal duplication of what Columbus is doing, and predominant duplication was in staff training. And because of the provider relations Medicaid waiver assurances and the corrective action plan we've been on for almost 3 years, no, we will gather all information in the review, not only for waiver assurances, but we need that data to establish the 1, 2, or 3-year cycles. If certification comes this year, will Columbus? Yes, we will endeavor to schedule separate from certification so as not to overwhelm providers. Can Columbus come at the same time as certification? We do not want to go down that road because both certification and Columbus interview individuals. Now, certification doesn't have a formal interview process. They don't use the CAHPS. The CAHPS is a specific HCBS approved tool. So we don't want to be conducting 2 interviews with individuals at the same time. I didn't get this spelling error corrected. I did spell check, and ow is a word because it didn't find it. But the question is, when will we know when Columbus is coming? And the answer is we're targeting the same month as your last PR review, and the TCM review is being scheduled per the existing process. They're following the same schedule that the tax were. As Columbus reviews 100% of records, does the contract language around self-audit and corrective action plans still apply? And this is related to service providers. So in essence, because they're doing 100% review, they're completing the audit for the providers. So no additional audit will be necessary. However, if that provider's results are less than 87% per the contract, the corrective action plan will be implemented. It's simply removing that self-audit component. We're doing that for you. Will Columbus provide technical assistance to providers? Yes, but it's only limited during the review process. Provider relations and TCM technical assistance coordinators continue to provide technical assistance on all waiver activities. And as Dan reviewed, if there's a finding, they work with that provider for 30 days to remediate. If at the end of that 30 days, after 2 attempts, they can't come to remediation, that gets passed to PR and tax. Columbus won't be able to achieve the objective and the sample sizes that we've set before them if they're spending months trying to remediate with a provider. So that will bounce back to division staff. So I want to go back through because we have time. I think we've answered all questions, but I don't know how well people are reading the chat themselves. So I'm going to go back to look for questions. You can post new ones while we're doing it. Clarification and someone asked if an agency provides both waiver services and also supports people with general revenue funding, who does the review, PR or Columbus or both? Columbus does only waiver related services. PR will do general revenue. And I wrote that answer in there. Greg asked, will be consideration on late LOCs when the MOS simply can't get scheduled or rescheduled prior to ISP implementation? And I'm going to repeat this in case you all couldn't see it. Yes, there is the possibility that that could occur. The Mojave, Vineland, and ABES are all valid for 3 years from their last date until November 11th, 2023. A support coordinator can generate an LOC based on the current assessment. You don't need a new assessment if the last one hasn't expired. So many support coordinators are asking for MAS for annual LOC instead of using their Mojave, ABES, Vineland. You can use that old assessment, not old, it's current because it's not expired yet. You can use that assessment to complete your work. And then if you need the MOS for an RAS or a PON, ask for it, or you need that MOS for the next annual plan. So you need to ask for it, but you don't have to wait on it to complete your LOC. Now, Greg did say that he's had some instances where it has expired. It's expired before the 90-day ability to complete an LOC, which really has me scratching my head. But so if your Mojave, Vineland, ABES expired before 90 days from the implementation of an ISP, then yes, you're going to need a MOS in order to complete it. Most support coordinators, well, not most, many support coordinators have figured out the demand for the MOS, and they are asking and scheduling for the MOS 4 months, not waiting till the 90-day mark. They're starting to plan earlier than that. But just on a side note, this training is not about the MOS, but just since we have the audience, just wanted to share with you that we are adding interviewers to the MOS. We're also adding clerical support, and we're meeting with Calendly tomorrow to address calendar issues, including some sort of system to prevent people from creating duplicate appointments. We literally had one support coordinator who scheduled the same person 21 times. So we need a system that will not allow duplication, because that is impacting other support coordinators' ability to get scheduled. So we're working on that. So I'm not going to answer any more MOS questions because this isn't about the MOS. But while we have the audience, I wanted to put that out there. There will be guidance coming soon. Tina responded, we don't receive the plan of action or of a provider for an investigation. I'll pass that on. That's not, it doesn't pertain to what we're talking about here today, but I'll pass that on. Greg asked, I thought the on-call was managed by call centers at KCRO now, and TCMs didn't have to have their own on-call. And Carrie answered that here in a moment. Emily provided clarification. In the presentation, I said HCBS compliance is required by May. I used the wrong M. It's March, so it's already come and gone. Last month was March 17th, 2023, was when providers were required to be compliant with the HCBS rules. So thank you, Emily, for being here and for helping out. Okay. Carrie responded to the question about the TCM using the regional office on call. And she said the TCM provider would be responsible for their own. Oh, wait a minute. Sorry, that's not right. This is in relation to the MOS, Carrie. The TCM provider would be responsible for their own action plan. For example, if there's a plan of action to update the ISP due to incorrect information. In the past, provider review was also tied to CARF accreditation. Will this not be the case anymore? Not every provider chose to implement that cycle. Not every accredited provider chose to implement it at the same time as their accreditation. So the Columbus review will be annually for 2 years. So obviously, you know, unless you have, it very well could be the same year as CARF, but not necessarily. And then the 1, 2, or 3 year renewal may or may not be in line with accreditation. And we can work through some of those details when we get ready to implement that 1, 2, or 3 year. I do see what Columbus is doing will change based on the core data we collect in the next 2 years. So I expect a metamorphosis as we learn more about the provider systems and where we're really sitting with compliance. Tanya said that she went through the review of Columbus, and when they asked about the on-call system, she let them know what they were doing. That wasn't just Columbus, that would have also been with the TAC, so TAC would have been present as well, I think. Can we get a copy of the review tools that we'll be using? Absolutely. When we get them done, they will be posted, and providers will also receive them prior to their review. And Carrie answered a little more in depth about the TCM on call being managed by a regional office. And her answer is, per the TCM contract, the TCM provider must have a 24/7 on call. That might be to have the regional office take those calls. However, that would be noted in the particular TCM's agency process. Our staff complete their documentation on our EVV app where there is not a signature. Do we need to look into finding a way for them to sign? No, the EVV generates an electronic signature that's acceptable. So if you are using an approved EVV system, you're good to go. See if we have, yes, providers will be invited to the table to develop the provider scorecards. Are there regulations for out-of-homes, respite, standalone facilities? We just went through DMH certification. They do not have them either. They had to certify us according to group home regs for out-of-home respite. Do we know when these will be developed? Also, will we have a review of out-of-home respite standalone facility from Columbus, Org? Yes. Yes, Columbus will review the out-of-home respite service through the CAPS and through staff evaluation and records. So no, there is no standalone respite, out-of-home respite facilities don't have a requirement like group homes and CSR. So I will follow up with certification. We've had as you all know, had a change in leadership and certification. So I will follow up with them on what we need to do for that. It is a different system. It is a different mechanism, and I do not believe had intended to review them as we review group homes. And we can't, because if you look at fire marshal, well, possibly, if you look at the fire marshal regulations for group home, there are none when you reach a certain size. I can't remember what the number is. Can't remember what the bed size is, but there's no fire marshal regulation around group homes until you reach a specific size. So, so we'll take a look at that. All right. I got through the list of questions. I see we've lost some people, but I appreciate everyone sticking around. We will get this recording posted out. And we will share the tools when they are available. Thank you for your amazing questions and for helping us figure out how to make Missouri a more compliant HCBS system. We truly cannot do it without you, and vice versa. We have to do this together. So hopefully we will gather great information, and eventually we will get to a more systemic review of providers' systems. So thank you so much, and you have a great day. Appreciate you.